Okay, thank you very much. Good afternoon, everyone. So I'm going to talk to you about conduction system pacing, but before we start off with that, we're going to go back to the basics. And so the first implantable pacemaker in man was in 1958. It was an epicardial device, and it only was in the mid-1960s that we started using transvenous leads. At this point, about 1 million people get a pacemaker every year, and it has helped, of course, enormously the patients with brady problems. However, we have seen over the years that RV pacing is associated with certain side effects. And so in the MOST trial, what we saw is that a high level of RV pacing was associated with a larger prevalence of atrial fibrillation and heart failure. And we know this because this is due to the RV pacing that creates a poorer hemodynamic function. Because of the loss of the mechanical coordination. And if this is perpetuated for a long time, we see an adverse ventricular remodeling. Of course, the question in all the studies is how much is substantial RV pacing. And so the data of the registries that describe tachycardia, pacing-induced cardiomyopathy, define substantial RV pacing in very different ways. But the recent documents actually propose that substantial RV pacing is more to 20 to 40% of RV pacing. And when we look at what we see in the ventricle, due to pacing, we actually see something that is quite similar to what patients have that have an LBB cardiomyopathy. So actually, both diseases are now described under the dysynchronicity induced cardiomyopathy. And what we see is people with LBB over time, they have a deterioration of their ejection fraction, they have a dilatation of the left ventricle with the asymmetric hypertrophy. And at the molecular level, we see dysynchrony that occurs, and we see apoptosis, hypertrophy, and fibrosis. And we know that if we try to resynchronize this ventricle, then this part of this disease is reversible. And so a lot of trials, very big trials, have been done over the last years. You see a few of them there, and they have shown that cardiac resynchronization therapy reduces all-cause mortality, it reduces heart failure events, improves symptoms and quality of life. And the efficacy of CRT has also improved over the years due to the optimization of use of better leads, quadripolar leads, better AV optimization, also of the software of the devices. Oh, sorry. Yes, okay. Nonetheless, we see that if optimal medical therapy is given to heart failure patients and then we give them a CRT, not all patients are responders, and there is still about 30% of the patients that do not respond, do not have enough benefit as we would like it from this CRT device. And, well, the question is there are certain, of course, limitations to the ventricular pacing. What you do is you put in an RV pacing lead and you put in an LV pacing lead, and you actually create a fusion of two wavefronts, which is actually quite different than using the normal physiological pathway. And sometimes it's not so easy to have a perfect fusion of those two wavefronts because you have limitations during the procedure due to an absence of a suitable vein, phrenic nerve stimulation, or LV scarring, which can all contribute to not correct resynchronization of the ventricle. So this actually led the rationale to looking at the conduction system pacing, because we try to heal what is broken. And if we look at this study, they looked at patients with AV block, and they looked at where is the problem. And you see that about 50% has the problem is located in the AV node. And the major part of the other group, it is actually an intrahischian block, which means that the largest part of these patients have actually quite good functioning conduction system, and we should actually try to maybe access that to allow for a normal and direct activation of this conduction system. And so here the conduction system pacing comes in, and so it's actually made up of two parts. Is you have two groups. You have the His bundle pacing and you have the LBB area pacing. And so to have a first look at the His bundle pacing, so actually the first patients that received that was already in 1970s, and where they saw that patients with left bundle branch blocks, they could normalize the QRS complex using His bundle pacing. So the His bundle, we know it's a relatively small area between the AV node and the bifurcation of the His bundle. And so the fact that the region is actually quite small is also one of the limitations of the therapy. The His bundle is also a relatively fine region, which when you put the lead in, it creates less lead stability over the long term, and which leads to the fact that sometimes in acute phases, the capture thresholds can be fine, but even if that is the case, there we see a late rise in the capture threshold. Another problem of His bundle pacing is that you have some oversensing of the atrial signal, and you can have an undersensing of the ventricular signal. And then if we are looking to it in patients for the future, and we're looking at combining it with AV node junction ablation, then we have to be careful that we do not go too close to the lead to have worse thresholds on the long term. So then let's have a look at the other group of conduction system pacing, that is the left bundle branch area pacing. So this is also subdivided again into three distinct areas, being the real LBB pacing, the LV septal pacing, and the left vesicular pacing. And so what are the advantages of LBB? Well, we actually are able to create an almost normal LV activation pattern. And it shows on the QRS in a very narrow QRS waveform. We are able to do that with low pacing thresholds and good sensing values. And we actually see that these values remain more stable over time, probably due to a better fixation also of the lead, because we have more muscular septum to stabilize the lead, and the fact that the values remain good over time also makes it possible to not have to put in an RV backup pacing lead in these patients. So here are a little bit the data that is available now, and you can see that the range is actually quite short. So let's have a look at them. So this is actually first thing in 2016, where they took patients with 10 patients with sinus node dysfunction who had to have a pacemaker, and they looked at the effects, the hemodynamic effects, if they would pace in the right ventricular apex, in the right ventricular septum, or deep in the LV septum. And they actually saw that the QRS duration was the shortest with the patients receiving LVS pacing. But they also more markedly showed that the hemodynamics were actually quite similar with LVS pacing compared to baseline. So their actual, the proper conduction of the patient, and it was actually reduced when you applied RV apical or RV septum pacing. So a second case report actually is of a patient, a woman, 40 years of age, I believe, and she had a non-ischemic cardiomyopathy with a left bundle branch block. And so she had a CRT indication, and they went for CRT, but it failed. And then they tried backup His bundle pacing, which also did not have the desired effect. And so they tried then to go for LBB pacing. And in 1 year follow-up, they saw a significant improvement of clinical outcome, but also, more importantly, a very much improvement of the left ventricular ejection fraction. So, and now we go look a little bit more at big numbers. And so this is the MILOS study, which is a multi-center European study. It's a observational study where with 2,500 patients who received LBB, there were different types of leads that were used. And we see that the implantation success rate was quite high. There's a clear learning curve needed to be able to provide good LBB pacing. But we see actually that during the follow-up of 6 months, the thresholds and sensing values remained very stable. Sorry. I'm not trying to make you nauseous. Okay. And then here we have a randomized controlled trial. So it's from October 22. And okay, there's only 70 patients in this trial, but it was patients with heart failure that had a CRT indication. And they looked at changes in left ventricular activation time and reverse remodeling, heart failure hospitalizations, and death at 6 months. And they actually, it was a non-inferiority trial, and they saw actually that there was actually no big difference between the patients receiving ventricular pacing with CRT or conduction system pacing. Okay. Yes, and this is a second randomized control trial, also very small, of 40 patients with like a similar population group. And here also, so LBB compared to biventricular pacing. And they see that after 6 months, there's a significantly higher improvement in the left ventricular ejection fraction in the LBB group compared to the CRT group. And if we look at secondary endpoints, we see that the LBB group has a lower BMP level and a shorter QRS duration, and there is more response in the ejection fraction. It becomes better. The proportion of patients with more than 10% improvement of ejection fraction is greater in the LBB group compared to the CRT group. Okay. And then, so this is again an observational study, but also of about 1,800 patients, also with heart failure and CRT indication. And here also we see that the paced QRS duration in LBB is significantly narrower than baseline and also significantly more narrow than the patients receiving CRT. And if we look at time to death and heart failure hospitalization, we see that the LBB group is doing better. But what about patients that do not have heart failure and they just need a pacemaker? So this is an observational study of 700 patients who are randomized to either get LBB or RV pacing. And you see actually that for the primary composite endpoint of mortality, heart failure hospitalization, or upgrade to biventricular pacing, the LBB group is doing better. This is mostly also due to the fact that the patients that received a classical RV pacing and had a lot of RV pacing developed more heart failure and of course created the negative trend for the RV pacing group. So these are the studies, but I think then if we want to go further, we actually need to work on the standardization of LBB implantation. I think if we want to have big data and we want to do nice trials, we all need to speak a little bit the same language. And so a lot of work has been done about creating consensus documents, about the use of different types of leads, different types of catheters to help us choose the right spots and be able to reach the right spots. And there are different documents that describe what we need to be looking at before we start, before we accept that the point that the region that we have is the right regions. We look for the W sign in V1, the AVR and AVL discordance, and R wave in 2 and 3. And if you look here in V1, you see as the lead goes further into the septum, you see that the W sign disappears, and you get this very nice RBB-like morphology in V1. And you see also that our wave peak time decreases progressively up to 68 milliseconds. And so we know now, we have documents that tell us where to choose the right spot. We also have other data to tell us when are we at the right spot, because if we go too far, we perforate. If we do not go far enough, we will not have selective capture. So there are different algorithms. I think this is a very nice one about from the European consensus document that tells us actually step by step when we are in the right spot and what are we supposed to be looking at. Of course, LBB also has its own complications. Something that is typical is, of course, septal perforation that you will not have with other devices. Of course, the complications are also related to the skill of the operator. So it's a new technique. That means a lot of people are starting up. The tools are getting progressively better. But in the meantime, while there is a learning curve, the complications will be high. But I think that from our UZ Brussels experience, we must say we don't have a lot of complications, but of course everything depends on how often you do it and how you do it. And then, of course, what are the limitations of LBB is that, of course, the data that we have at this point is limited. However, this is growing very fastly and it seems very promising. We will need to look at long-term safety and efficacy. And also we will need to look what we are going to do in the long term if there is indeed a lead problem and we would need to extract it in a long time, how we will do that. So I have just one small case for you in the last few minutes. So it was a 68-year-old patient with ischemic cardiomyopathy that came for symptoms of dizziness and syncope. And he had a known right bundle branch block. And so this was his EKG beforehand. And he was hospitalized. We saw different moments of high degree AV block also. And this is actually his EKG after the implantation. And what we do in patients that receive an LBB is we do a CT scan with a vest of Medtronic to look at the activation. And what you see in the top picture on the right is the activation of his normal conduction with a delayed activation of the right heart due to his right bundle branch block. And the second picture is the one, the activation after implantation. And then I will try to make this work. Yes. So here you see actually the activation front, which is completely simultaneous in both ventricles with the pacing. So what do the guidelines say? Well, the 2021 ESC guidelines don't say a lot. They mention his bundle pacing once here below. As bailout for failed CRT, but that's it. It's probably due to the timing that the guidelines were written. But there is a very nice ERA consensus statement that talks about standardization of the implantation, but doesn't say anything about guidelines about who to implant and what. But that will hopefully come soon. The American guidelines are there, and they were published in September. And for the sake of time, I will not go through them. But what I would just like you to see is that there is actually a lot of incorporation of conduction system pacing into these guidelines that, of course, the level level of impact is lower. The level of recommendation is lower. Of course, it cannot be anything different because with CRT, we have more data, more trials. However, nonetheless, it is put in quite a high level of recommendation. And this is for heart failure patients, for patients that need pacemakers, for body indication, and also for patients with atrial fibrillation. So my conclusion is high level of RV pacing is a problem. It leads to heart failure. It's better to prevent than to cure. Conduction system pacing allows for a physiological way of pacing. And so the current evidence that we have looks very promising. And we are waiting for long-term data and large randomized trials to see where this goes, but it looks good. Thank you.